Hello, everyone, and welcome to our module on sarcoidosis. Sarcoidosis is a multi-organ system disease, and we'll talk shortly about all the different organs that can be involved and what clinical features those lead to. But an important thing to know about sarcoidosis is that it's a classic example of a disorder associated with granulomatous inflammation. I talk about granulomatous inflammation in detail in the pathology section, but it's a specific type of chronic inflammation. And when there's granulomatous inflammation, granulomas form in the body. That's why it's called granulomatous inflammation. And we'll talk about what a granuloma is in a minute, but those form in many places throughout the body in sarcoidosis. Sarcoidosis is considered an immune-mediated condition. The immune system plays a central role. We think the immune system is reacting to some antigen, but the exact cause is unknown and has never been discovered. The hallmark of sarcoidosis in terms of pathology is the widespread development throughout the body of non-caseating granulomas. And the word non-caseating is very important. That distinguishes the granulomas of sarcoidosis from other conditions like tuberculosis where the granulomas are caseating. So caseating refers to the development of central necrosis inside of granulomas. That doesn't happen in sarcoidosis, but it does happen in tuberculosis. So the granulomas of sarcoidosis, which are non-caseating, are these circular structures. This is one shown on the slide here. They have a tightly packed central area that contains lots of macrophages, also transformed macrophages that form into cells called epithelioid cells, and then multinucleated giant cells, which are collections of multiple epithelioid cells. And all these cells, which are in the tightly packed central area like macrophages and epithelioid cells, are surrounded by other immune cells like lymphocytes, monocytes, mast cells, and fibroblasts. And these things all form these collections of rounded areas called a granuloma. In the granulomas of sarcoidosis, you can find giant cells, which are multiple macrophages that have fused together. And in the cytoplasm of those giant cells, you can sometimes find special types of intracytoplasmic inclusion. So let's talk about those now. The first is called an asteroid body. This is an eosinophilic inclusion made up of lipids. This is a picture of one right here on the slide. You can see this funny looking thing with little purple lines through it. That is an asteroid body, often found in the giant cells of sarcoidosis. It derives from pieces of eosinophils and it's made up of lipids. Another finding, which I don't have a picture of to show you, is called a Schaumann body or a conchoidal body. These are round oval inclusions of calcium oxalate, and you can also find these sometimes in the giant cells of patients who have granulomas of sarcoidosis. The pathology of sarcoidosis is very complex and it's incompletely understood. But on this slide, I'm going to give you some of the key points you want to remember in case they come up in board questions. So first of all, it's a cell-mediated immune process, so antibodies are not critical to this process as far as we know. You should also know that in sarcoidosis, there's an accumulation of Th1 CD4 positive helper T cells. In particular, when they do bronchoalveolar lavage and they extract cells from patients who have sarcoidosis in the lungs, they find a high ratio of CD4 to CD8 T cells. This is a very consistent finding in bronchoalveolar lavage samples. This is the kind of thing that could come up on your STEP exam. These T cells are believed to secrete IL-2 and interferon gamma. The IL-2 stimulates T cell proliferation, the interferon gamma activates macrophages, and then all of these things come together to lead to the formation of granulomas. So some of the key things to remember about the pathology are that CD4 positive T cells are very important, so is IL-2 and interferon gamma. And then remember this CD4 to CD8 ratio because this has been consistently shown in lung samples of patients with sarcoidosis. Okay, so that's the pathology. Now let's talk about all the different organs that can be involved. So first of all, sarcoidosis is famous for the fact that any system can be involved. But the lungs are the most common site of involvement, and that's why we're talking about sarcoidosis in the pulmonary section. But we'll also talk about how patients with sarcoidosis can have involvement of all of these organ systems listed here. So in the lungs, when this inflammation occurs and granulomas start to form, this often leads to nonspecific pulmonary symptoms like cough and dyspnea. A classic finding on chest X-ray in patients who have pulmonary sarcoidosis is the presence of hilar lymphadenopathy. Hilar lymphadenopathy refers to enlarged lymph nodes in this region here on either side of the heart and the mediastinum. You can see hilar lymphadenopathy in tuberculosis as well, but it is a classic finding in sarcoidosis too. If the sarcoidosis is advanced and doesn't respond to treatment or goes untreated, eventually there can be so much inflammation throughout all the lung fields that pulmonary fibrosis can occur and restrictive lung disease can develop. In fact, the lung involvement of sarcoidosis goes through a number of stages. I don't think you need to know these for your step exam. I'm just telling them to you so you have a picture in your mind of how the disease progresses. So initially, the granulomatous inflammation leads to bilateral hilar lymphadenopathy, like what you see here. That's called stage 1. In stage 2, patients have hilar lymphadenopathy, but they also get parenchymal involvement. What this usually means is there are little opacities that develop out here in the lung fields. They're usually described as reticular and nodular opacities, and this is called stage 2. And then patients with stage 3 sarcoidosis of the lungs can have parenchymal involvement without the hilar adenopathy. And then finally, stage 4, as we mentioned earlier, is when pulmonary fibrosis develops. The skin involvement of sarcoidosis can take on a number of different forms. There are many, many lesions that are possible that have been described, but the classic lesion you should know for your board exams is erythema nodosum. This refers to chronic inflammation of fat cells under the skin. It presents as tender red nodules, usually on both shins. This is a picture of what it looks like on the slide here. Another potential skin problem related to sarcoidosis is called lupus pernio. This is a cutaneous or skin manifestation of sarcoid. It's much more common in patients who have black skin. It involves plaques that form primarily on the central face. This is a picture of a woman who has lupus pernio on the slide here. Sometimes the lesions can become purple. They're described as violaceous, or they can become red. This is described as erythematous. This is an example of a violaceous or purple lesion here. There's another example right here. Sarcoidosis can involve many parts of the eye, but the classic eye problem from sarcoidosis is uveitis, which I talk about in videos on the eye in the neurology section. Patients with sarcoidosis can develop anterior uveitis, which is inflammation of the iris and the ciliary body. They can also develop posterior uveitis, which is inflammation of the choroid. Usually this causes only mild symptoms, things like dry eyes or blurred vision, and it's often detected on routine eye exams, so patients who have sarcoidosis who go to the ophthalmologist will often have these lesions identified. Patients with sarcoidosis can have involvement of the central nervous system. Lots of different lesions can develop, but often it's a cranial mononeuropathy, meaning a single cranial nerve on one half of the body is involved. Classically, this is a Bell's palsy, which is a nerve palsy involving the facial nerve that leads to facial droop like what's shown here, and I talk about this in much more detail in videos in the neurology section. But of patients who have neuroinvolvement of sarcoid, meaning neurosarcoidosis, up to 50% of those patients will have a facial nerve or Bell's palsy. The parotid gland is sometimes inflamed in sarcoidosis. Many patients who have sarcoidosis develop painless swelling of either the salivary or parotid glands. This is a less common clinical feature. It only happens in about 5% of sarcoidosis patients. But sometimes the enlarged parotid gland, which is right near the facial nerve, can actually compress the facial nerve. And that's one of the things that can lead to the facial nerve palsy we talked about on the last slide, in addition to simply having sarcoid inflammation involved in the facial nerve. Some patients with sarcoidosis develop arthropathy, meaning joint pain. This can present as an acute, meaning the rapid onset of joint symptoms that involve multiple joints, so an acute polyarthritis. For reasons that are poorly understood, this often involves both ankles on both sides of the body, meaning it's symmetric. Beyond this, patients sometimes develop a chronic arthritis as well. This is an inflammatory arthritis because sarcoid is an inflammatory condition. It often involves multiple joints, and it can look a lot like rheumatoid arthritis, occurring in a patient who has other features of sarcoidosis. And then the kidneys can be involved as well. Sometimes the kidneys develop what's known as nephrocalcinosis. This refers to calcium buildup in the kidneys. This relates to the chronic inflammation driving calcium buildup in the kidney tissue. If this is extensive enough and goes on long enough, it can eventually progress to renal failure. In addition to this, sometimes patients develop an acute kidney condition, acute interstitial nephritis. I talk about this condition in videos in the renal section, but it can be brought on by patients who have sarcoidosis. Some other sarcoidosis features you should know about. The things on this slide are particularly high yield for step 1. First of all, sarcoidosis can lead to hypercalcemia. How does this happen? Well, the enzyme 1-alpha hydroxylase converts vitamin D to its active form, and it's normally found in the kidneys, but it can also be found in alveolar macrophages among patients who have pulmonary sarcoidosis. This leads to too much active vitamin D, so patients can have high levels of vitamin D3 calcitriol in its active form. When sarcoid raises the active level of vitamin D, that causes the gut to absorb more calcium, and so the patient develops hypercalcemia. The parathyroid glands will try to respond by lowering the amount of parathyroid hormone to bring down the serum calcium, but this won't work because there's too much active vitamin D. So everything shown on this table here is particularly high yield for your step 1 exam. You should also know that patients with pulmonary sarcoid can have high ACE levels. This is a nonspecific finding. ACE, which is angiotensin converting enzyme, it's part of the renin-angiotensin-aldosterone system. It comes from the lungs, so in many lung diseases, the ACE level is elevated, but it's commonly found at an elevated level in patients who have pulmonary sarcoidosis. So the classic presentation so that you can recognize sarcoidosis on your exams is going to be someone who has a chest x-ray showing hilar lymphadenopathy. They have pulmonary symptoms like cough and dyspnea. These are the type of things that should make you think of sarcoidosis. Incidentally, these things can also happen in patients who have tuberculosis, so you're going to have to look at other clues in the question stem to know whether this is, for example, an immunocompromised person more likely to have tuberculosis, or if it's a different type of patient who's less likely to have tuberculosis and may have sarcoidosis. And in actual practice, you should know that sarcoidosis is often asymptomatic and it's detected on a routine chest x-ray, which shows hilar lymphadenopathy, and that's how the diagnosis is often made. And then I'll finish with this slide on treatment. I don't think they are going to ask you about the treatment of sarcoidosis on your step exams. It's a complicated topic, but some of the things that are used are, first of all, corticosteroids like prednisone. The problem with these is that if you take them for the long term, they can decrease bone mass and cause other side effects. So often patients are tried to be switched from steroids to so-called steroid-sparing immunosuppressants like all of these agents shown here. These are drugs that can suppress the immune response and suppress the chronic inflammation of sarcoidosis, but they don't carry the same side effects as chronic steroids. And that concludes our module on sarcoidosis.